Today we learn about anchorage. To understand anchorage, we have to first understand what's the meaning of anchorage value. We have to know a little about classification of anchorage because there have been multiple classifications given by different authors. We'll just go through a few of them. How to reinforce anchorage, what is burning of anchorage, and the pressure response graph, which was given by William Prophet, which you can read about more in detail from his book on contemporary orthodontics. So let's get started. Before we start understanding anchorage, let's just go to the definition of anchorage. Multiple authors have given multiple definitions of anchorage, but the most important and commonly used are the ones given by Moyers, Prophet, and Nanda. Now, Moyers defined anchorage as resistance to displacement. That's all. Resistance to displacement. Obviously, when you say displacement, you're talking about displacement of the anchorage unit. Second definition given by Prophet, he said anchorage is the resistance to unwanted tooth movement. Again, he's referring to the tooth movement of the anchorage unit. Third is the one given by Nanda. He went ahead and he was more specific in this definition. He said that anchorage is defined as amount of movement of posterior teeth, the molar and the premolar, to close the extraction space in order to achieve selected treatment goals. So, what is anchorage value? Now we know the definition of anchorage. We know that we have, just imagine you have an arch, say it's an extraction case and it's a case of proclination, maybe maxillary incisors proclination, and you want to retract the anteriors. In this case, which is the anchorage unit? The posterior section of the arch, that is the molars and the premolars bilaterally, are your anchorage unit, whereas the anteriors, that is the incisors, laterals and canines bilaterally of the maxilla, are your unit that is to be moved. Okay, so every arch, wherever you see for orthodontic treatment, you have to divide them into two units. Imagine them as an anterior unit and the posterior unit, and now you have to think for that patient which is the anchorage unit and which is the movement unit. Now, what is the anchorage value? To understand this, you have to know what is the anchorage value. Now, what do you mean by anchorage value? Anchorage value is nothing but the sum total of the root surface area of all the teeth which are present in your anchorage unit. That means that in this case, in this picture, say it is a maxillary protraction case, we have to protrusive case, you have to retract the maxillary anteriors to correct the bimaxillary protrusion. For example, over here in the picture, we can see that the premolar and the first and the permanent molar bilaterally, upper as well as lower, will form your anchorage unit because this is the unit which should resist movement. As Moyer says, this is the unit which should resist displacement, and according Prophet, it should resist unwanted tooth movement. Now this is your anchorage. This is your anchorage unit. Now every root has a surface area. The greater the surface area, greater the anchorage value of the tooth. So anchorage value is defined as the total root surface area. So obviously, if you have roots which are larger, and if you have multiple rooted teeth, and if you have more number of teeth, you're increasing anchorage value of the anchorage unit. Now let's classify anchorage. We can classify anchorage in different ways. Now Moyes has given the classification of simple anchorage, stationary anchorage, and reciprocal anchorage. Now simple anchorage means it is the resistance to tipping tooth movement. Stationary anchorage means resistance to bodily tooth movement of the anchorage unit, and reciprocal anchorage simply means resistance of one unit against another. Basically, one unit is pitted against another unit. You have a condition wherein there are some situations wherein you really don't have an anchorage unit, in the sense that you do not want movement of only one unit. You want movement of both the anterior and the posterior unit, or both the left and the right unit, and you want it to move in equal and opposite direction, this is where reciprocal anchorage comes into play. One example of reciprocal anchorage, there are multiple examples, but one example would be use of expansion plate with jack screw. Now when you do that, you're pitting left side of the arch to the right side of the arch. For example, if you're giving an expansion screw with jack screw, expansion plate with jack screw for arch expansion bilaterally, in this case you will place the jack screw right in the midline of the expansion plate. By doing this, you're doing exactly the reciprocal anchorage. Basically, you're pitting the left side of the arch against the right side of the arch. That means that every 1 millimeter of expansion of the right side will result in 1 millimeter expansion of the left side. So, is there really any anchorage unit over there? In the sense that, is there any unit over there which is not moving? No, both the units, the left and the right, are moving. So, we want one movement pushing another unit of teeth to move in equal and opposite direction. Okay, so that's your in equal and opposite direction. Yeah, that's your reciprocal anchorage. Another classification is given by Nanda. He classifies anchorage as critical, moderate, and non-critical, also called as Group A anchorage, which is your critical anchorage, Group B anchorage, moderate anchorage, and Group C is your non-critical or mild anchorage cases. Now, most of the cases we see in clinical practice are either critical anchorage or moderate anchorage type of cases. Now, what do you mean by critical anchorage? Critical anchorage means that almost at least say 100 to 75% of the extraction space that is available has to be used for retraction or for correction of crowding. You have to be able to utilize at least 75% of the extraction space that is available. Say you have 10 millimeter of space, you should be able to use at least 7.5 mm of space for the malocclusion correction. That is not more than 25% of this extraction space can be afforded to be lost. Okay, so that's how crucial this kind of a case is. Okay, so in such cases you have to take every precaution possible to make sure that you don't lose anchorage. The second thing is group B anchorage or moderate anchorages, and this is also seen but in less complex cases where you can to some extent afford to lose anchorage, but then again, this rarely happens. This is rarely the need. In most cases, it's group A anchorage. Now, just in case you come across a group B anchorage, maybe it's a very mild crowding, very mild proclination. In this case, group B anchorage can be used. Now, when you say group B anchorage, you mean to say that you can utilize, or you just need up to 50% of the extraction space for your malocclusion correction, maybe proclination or crowding. You don't need more than 50% of the space. That means that you can afford to lose the remaining 50% of the space. Now, what do you mean by losing the 50% of the space? We'll discuss about that in the next slides. Okay, next is the group C anchorage, which is the non-critical or mild anchorage case. Now, this is rarely used, and you might as well say it's never used. Okay, in this cases, we had 70. Now let's just recall, group A is 75% of the extraction space at least has to be utilized. Group B is 50% of the extraction space at least has to be utilized, and group C is, even if you utilize 25% of the extraction space, it's enough. We don't need the remaining. Okay, so that's your group B and group C anchorage given by Nanda. Okay, now apart from that, there's also one more classification which is given by Gardner. Now we'll discuss about that at the last, but we'll go through some generalized classifications. Like, we can also classify anchorage based on its location. Is it inside the oral cavity? Is it outside the oral cavity? So based on that, you can divide it as intraoral or extraoral based on the site of the anchorage unit. Now, what do you mean by intraoral? It could be anything from transpalatal arch, transpalatal button. Okay. Now, intraoral can also be further subdivided into intramaxillary and intermaxillary. Intramaxillary anchorage units would be anchorage methods would be a use of a as the name suggests, intramaxillary. That means within the same arch. So use of a transpalatal arch is one way of increasing anchorage while being in the same arch, or use of a transpalatal button. Again, you're increasing anchorage by being in the same arch. Lingual arch, again, you're in the same arch and you're increasing the anchorage value of that same arch. So these are intramaxillary anchorage units. Now, intermaxillary anchorage units could be, one example could be use of intermaxillary elastics. So when you use a class 2 elastics from maxillary canine to a mandibular molar, or a class 3 elastic from mandibular canine to maxillary molar, you are using it's a kind of a reciprocal anchorage where you are exerting pulling force in equal and opposite direction. So lower, and for example, it's a maxillary class 2 case where the intermaxillary elastic is between the maxillary canine and the mandible molar. In this case, you're pulling the maxillary anterior unit posteriorly while your mandibular posterior unit is being pulled anteriorly. So you're having equal and opposite direction. So retraction of the maxillary anterior and protraction of mandibular posterior is desired, because by this you're creating a class 2 occlusion. So this is one example of your intermaxillary anchorage. So we're done with intraoral, and there's one more. There's called muscular anchorage. It's also intraoral anchorage. It's basically use of muscular forces, usually hyperactive muscular forces, to reinforce anchorage, increase the anchorage value of an anchorage unit. Now, one example of this, basically the most commonly used example, would be use of a lip bumper. So a lip bumper is usually containing an acrylic unit which is placed at least 2 millimeter anterior to the lower incisors. In fact, a little more than that. So up to 3 to 4 millimeter anterior to the labial surface of the lower incisors is the placement of the acrylic unit of the lip bumper. And because this lip bumper is lying, the acrylic unit is lying freely in the vestibular sulcus of the lowers, and this is usually given in patients with hyperactive mentalis muscle or hyperactive lower lip. So in that case, the force which is exerted by that is quite adequate to exert a pushing or a distalizing force on the lower molars. So again, you're increasing the anchorage value by using a muscular force. So that was your classification of anchorage based on the site of anchorage source. Now you can also classify anchorage as single, compound, and reinforced. Basically, single is where you have a single tooth pitted against another single tooth. One example would be closure of the midline diastema, where only one central incisor is pitted against another central incisor. Use of an elastic, so the left central incisor is being pulled towards the midline. Similarly, at the same time, the same amount of force is being exerted by on the right central incisor, which is also pulled equally to the midline. By doing this, yes, you're closing the midline diastema, although you're also creating space distal to the central incisors bilaterally, that is lateral to both the central incisors. Now you'll end up with space. But this is just one example of this is one of the examples for single anchorage. So you have one tooth pitted against another single tooth, whereas compound anchorage is sorry about that. Whereas compound anchorage is two teeth or more than two teeth are pitted against again another set of teeth. So basically your movement unit consists of two or more teeth, as well as your anchorage unit also contains two or more teeth. Then there is something called as reinforced anchorage. Now, reinforced anchorage is basically an additional anchorage. So use of transpalatal arch or nanspala button, they're all examples of reinforcing anchorage. You do not have that available naturally in the arch. For example, if you have more posterior teeth, more molars, or in the sense, if you have, instead of one molar, you have two molar or three molar, it's definitely increasing the anchorage value of that anchorage unit. Okay, but what if even that will not suffice, or what if it's a patient wherein the second molar is absent, or even the third molar is absent? So these are the cases wherein just using what is available is not enough. Just basing your taking support of the anchorage value that is present will not be adequate. We have to reinforce anchorage to enhance the anchorage value of the anchorage unit. So what do? You use extra things. You use auxiliaries like transpalatal button or a transpalatal arch or a lip bumper and many more that we'll discuss now. Then, so we know that Moyes classified it into simple, stationary, and reciprocal. Nanda classified it as Group A, critical, Group B, moderate, and Group C as non-critical or mild. Remember, 75%, 50%, and 25% of space utilization. And last but not the least is a classification which was given by Gardiner. And the classification which is given by Gardiner is a very generalized kind of a classification. And he basically classified it as, it's basically a combination of all the things which we already discussed. So he classified it as simple, stationary, reciprocal, which is like that of Moyers. Okay, so you have simple, stationary, reciprocal, reinforced, intermaxillary, and extraoral. So by doing this, you're combining 2-3 classifications at the same time. Okay, now yeah, so the pressure which is exerted on A1 is lesser than the pressure which is exerted on M1. So that is very critical. So what is it trying to say? It means that if you exert lesser pressure, there is lesser movement of the anchorage unit. This is also one of the reasons why unnecessarily excessive forces should not be used in orthodontic tooth movement. So not only does it cause hyalinization of your periodontal ligament space and hence increasing your resorption time and increasing your treatment time. So that's one problem of using unnecessary excessive orthodontic forces. You're actually increasing the orthodontic time and you are encouraging undermining resorption. So second problem with that is excessive use of force is that you lose anchorage. Yes, you will lose anchorage and you don't want that. Okay, so if you lose anchorage, you know that you don't have space available. That means that even after orthodontic treatment, you will not be able to achieve all your goals. So just make sure that you use lighter orthodontic forces, as light as possible, to exert orthodontic tooth movement. So you can see that A1 and M1 movement is higher. That means the movement unit, anterior unit are being retracted maximum and your A1 movement is less. And all this is because the pressure exerted on A1, let me just bring out a pointer. Yeah, because the pressure which is exerted by on A1, the pressure exerted on A1 is lesser than the pressure which is exerted on M1. Because of that, the amount of movement of M unit is more, which is exactly what we want. Whereas in case of A2 M2, we can see that the pressure which is exerted on A2 has increased. Just compare it. Okay, over here we have A2, the amount of pressure is somewhere on this area of the graph, whereas here on A1 you can see that A1 is almost half of A2. So because the amount of pressure exerted on the anchorage unit has increased, okay, the anchorage unit has also moved. You can see here it's over here on the movement axis, it's over here, whereas A1 on the movement axis is over here. So that means that the amount of movement that the A2 anchorage unit has shown is almost double of that of A1. So you have to some extent lost anchorage. Now if this is a moderate anchorage case, no problem. But if it's a critical anchorage case, we need 75% of extraction space at least available for orthodontic correction. It's a bad news. So here you can see it's movement of both A2 and M2 that has taken place. In the third example, you have A3 and M3. So you can see in this case what has happened is the anchorage unit and the movement unit both have moved. But unfortunately, the anchorage unit have moved more. It's almost at the same as the A2 unit. So anchorage unit has moved. Yes, it has moved a lot. But look at the movement unit. It lies somewhere here. So you can see it's somewhere here. So that means just imagine you have an anterior retraction case, you want to retract the maxillary anteriors, and instead of moving your maxillary anteriors, you've actually moved the maxillary posteriors ahead. So you have not retracted the anteriors. At the same time, you have protracted the posteriors. So you have not only lost the anchorage, you've not done the orthodontic correction. So, imagine that's basically a nightmare. Now, this rarely happens. If you lose anchorage, you end up with A2 M2 kind of situation, because by the time the case is going towards this part of the graph, you realize what's happening and you correct it. But usually you see A1 M1 and A2 M2 kind of occurrences. Now, what's burning anchorage? Now, burning anchorage is every orthodontist's nightmare. It's basically losing anchorage. Burning anchorage is another way of saying you are losing anchorage. Okay, you're destroying anchorage, and anchorage is precious in orthodontics. Now, this particularly comes into play where you have a group A anchorage case, or even when sometimes you have a moderate anchorage case, but it basically refers to a group A anchorage case. So when you have 100% to 75% of utilization of space that is required, and you end up losing some amount of anchorage, that is basically you are losing some amount of extraction space. Okay, and that's an example of losing anchorage or burning anchorage. Okay, so that means that the amount of space is that's available after losing anchorage is so less that you will not be able to reach your orthodontic treatment goals. Okay, so these are the reasons why anchorage is important, and anchorage has to be planned during the initial treatment planning stage itself. So not only you do diagnosis, you also do treatment plan when you analyze a case. So when you're doing that, your anchorage planning is crucial and has to play a very important role in your treatment planning. So you have to sit and think about what anchorage will be good. First of all, you have to classify it. Is it a moderate anchorage case? Is it a maximum anchorage case or critical anchorage case, or is it a very mild or a non-critical anchorage case? And there's also the third one, which is called absolute anchorage case. Now, before that, there's something called as cortical anchorage. Now, cortical anchorage was mainly utilized by Ricketts. He emphasized on cortical anchorage. He basically said that if the root comes in contact with the cortical bone instead of the medullary bone, which is very spongy, we know that cortical bone is thick, dense, and it's compact, whereas the medullary bone is spongy, it's more vascular. Okay, it's more, it's more airy. So cortical bone has the ability, once it makes contacts with the root surface area, it resists movement of the root. So by doing this, what are you doing? You are increasing the ability of the root to resist movement, hence you're increasing the anchorage value of the anchorage unit. But now, what's the catch? The catch is that these kind of situations are known to increase the risk of root resorption. So this is controversial. Although Ricketts spoke about that in detail, he said that this is a very good way of increasing anchorage value of the anchorage unit by tipping the teeth and making them contact the cortical bone and hence increasing the anchorage value. But then yes, studies have proven that by doing this there is a risk of root resorption, and we don't want that. Another condition wherein cortical anchorage comes into play naturally is extraction site. So in this picture, we can see that over here there is a spongy bone, the cancellous bone, which is highly airy and vascular. It contains multiple capillaries which are rich in blood and that carry inflammatory mediators, facilitating the whole resorption and deposition of orthodontic bone, hence resulting in movement of a tooth from point A to point B. We know that already. Now, we have the cortical bone on the outside. We can clearly compare how the cortical bone is dense, thick, and more or less avascular. So that's why Rickett proposed the whole cortical anchorage phenomena. Now, but the thing is, studies have proven that it is not advocated. So when we have evidence that says that it's not a good idea, we'll not be doing it. Okay. So now, what about the extraction? In this example, you can see that it's an extraction site. It's an old extraction site. I think it was a year old. This was a picture from Dental Economics blog, and you can see that it's kind of shrunk. Okay, so basically, this if you take a cross section of this area, you will see that the cancellous bone is very less, and it mainly contains the cortical bone. And we already know that cortical bone does not let you walk through. Cortical bone is resistant to tooth movement. Now it's okay where in cases wherein you don't want to protract the posteriors. For example, in this picture you can see that the molar, we know that because of this old extraction site over here, the molar will not move. That's a good thing, isn't it? You're increasing the anchorage value of the posterior unit, for example, in case of a group A or a group B anchorage. Okay, particularly group A anchorage, I wouldn't say group B anchorage. But then what's happening is at the same time, your anteriors are not able to come backward. Okay, so you are able to resist movement of the posteriors from moving, but then your anteriors are also unable to move. So this is not the kind of anchorage that we want. We want the anchorage such that it allows movement of the M unit but resist movement of the A unit. But you can clearly see here the extraction site is completely, it's calcified and it's lost its cancellous bone. It has shrunk. The medullary bone has shrunk, and what you see is mainly cortical bone. You basically lost the arch width. You lost the ridge width, and by doing this, you actually made it difficult and almost impossible for the anteriors to move posteriorly. Okay, so that's why orthodontic extraction has to be carried out carefully, and missing teeth had to be replaced. That's the importance. Over here we can see that we have a tooth that has got completely ankylosed. You can see that this is a root canal treated tooth, okay, and very clearly this has been there for a long time. You can see that the periodontal space is completely lost. You cannot see any demarcations, whereas over here you can appreciate the demarcations of the periodontal ligament space and the cementum root surface area. Okay, same on this side. You can appreciate the periodontal space and the cementum surface. Everything can be appreciated. This root canal treated tooth has still retained its roots, has retained its root canal fillings, but it has lost the periodontal space. Why has that happened? Because that has gotten calcified. This is an example of an ankylosed tooth. Now, if this ankylosed tooth is present in the posterior unit and you have a critical anchorage, that is a group A or a group B anchorage, it's good news, because by doing this, and you're naturally gifted with a increased anchorage value. Okay, another way of artificially using this method is use of temporary anchorage devices, also called as TADs. Now they are called by different names. They're also called as skeletal anchorage devices or mini screws or mini implants, and we'll discuss about them in detail in another. Coming to temporary anchorage devices, just a little introduction. Temporary anchorage devices or TADs are also called as skeletal anchorage devices and many other names. Okay, they also call as mini implants. Right now, these days, more of screw type devices are used instead of plate type devices. Mini implants or mini screws are basically they are miniature versions of the prosthodontic implants, but they are not the same as the prosthodontic implants. The reason being, prosthodontic implants are supposed to be there as long as possible, okay, for at least 10-15 years. Okay, now it depends from case to case. Of course, it depends on the prognosis of the prosthodontic implant case, but just to give you a comparison between prosthodontic implant and an orthodontic implant, the orthodontic treatment will not last for 10-15 years, right? The orthodontic implant is supposed to last at least for a year. Okay, that is during space closure or anterior retraction or decrowding or extrusion. So during those excessive strainful orthodontic tooth movements, we have to place them the implants. But when you want to consolidate the space, you remove the implant. So orthodontic implant are supposed to last maybe a year or maybe a year and a half, not more than that. So it need not completely ossify with the bone. So that's your significance. It has to form a good contact between the bone and the orthodontic surface. Yes, all those things are true, but then it need not ossify the way a prosthetic implant is supposed to be ossified, because it's not supposed to be there in the bone. We have to remove it after your orthodontic correction. Now, these are different names: orthodontic implants, TSADs, temporary skeletal anchorage device, TADs, temporary anchorage devices, mini screws, mini plates. Okay, we can see that at the tip of this orthodontic implant is a screw-like area. Okay, now we can see that this screw-like area has a rim. This basically encourages placement of elastics. Okay, so you can hook orthodontic elastics into these rims. Okay, so this gives you a point of hook, a point of attachment to exert orthodontic forces. Now, the advantage of this is that these are directly embedded into the bone. Okay, so it's basically giving a site to exert forces without resulting in any undesirable movement of teeth, because the teeth that you want to move, the M unit, is connected to your elastic at one end, okay, and the other end of it is directly hooked in the bone. Okay, now bone is not going to move, so no undesirable tooth movement are taking place when you're using tats. That's the advantage. The use of tats are also called as absolute anchorage cases, okay, or highly critical anchorage cases, wherein almost 100% of the space has to be utilized. So not 75, almost 100% of the space has to be utilized, or 90% of space to be utilized. So it's called absolute anchorage case, because you're almost absolute anchorage. That is the anchorage unit is not moving at all, because the force is not at all being exerted. The rebound force is not being exerted on the anchorage unit. So you're kind of bypassing Newton's law, Newton's third law, by use of that. Now we know that there are different types of anchorages. We know that some cases are group A, some are B, and some are C type anchorage. Now, how do you control anchorage? In this picture, you can see that the roots surface with higher surfaces have a higher anchorage value. We can see that the maxillary first permanent molar has an anchorage root surface area of 533. Hence, it has the highest anchorage value in the maxilla. And after that, the mandibular first permanent molar, and then the second permanent molar of the maxilla, and the mandible followed by the canine of the upper and lower, and so on. So we know that the greater the root surface area, the greater the anchorage value. Similarly, the shape of the root is also important. The number of the roots is also important. The greater the number of the roots, the higher the anchorage value of the tooth. Similarly, the shape of the root, for example, if you have a root which is triangular in shape, conical in shape, it has higher anchorage value over a root which is round in shape, because it will be less resistant to tooth movement. Okay, now so by doing this, you're basically saying that you can increase anchorage value of teeth by including more number of teeth, by including teeth with more number of roots. By doing this, you are increasing the ability of the anchorage unit to resist tooth movement. According to Ricketts, to move a tooth, you need at least 100 grams per centimeter square of force. And by using lighter orthodontic force on M1, you are having a lighter reactionary forces exerted on A1. So you're having a group A anchorage creation in your case. So by doing this, you're losing less anchorage and you're utilizing almost 75% of extraction space. And say you're not happy with just 75%, reinforce it with a skeletal anchorage device with a TAD, getting an absolute anchorage. We know how to reinforce anchorage. We can reinforce it by using intraoral methods and extraoral methods. Now, intraoral could be your intermaxillary or intramaxillary, and if that is also not enough, you can reinforce it again with the help of TATs. That is your skeletal anchorage. Just keep in mind that the anchorage value of anchorage unit should be at least 2 to 4 times that of the movement unit. That is, your anchorage value of A1 of A should be at least 2 times that of M. Okay, or else you're going to lose anchorage. It's better to be to err on the safer side. So try to have an anchorage value which is like 4 times that of the M unit. So if your M unit has a root surface area, your teeth movement unit has a root surface area of 100, your anchorage unit should have at least a root surface area of 400 or more. Now we already know that transpalatal arch is an example of your intramaxillary anchorage. By doing this, you're resisting the anterior posterior movement of your molar, hence you're increasing the anchorage. Then this is an example of your intramaxillary anchorage with the help of molars and the anterior hard palate. We know that palate has a more of a cortical bone, hence more resistant to anchorage. You're reinforcing anchorage with the help of. This is the example of your intermaxillary anchorage or reciprocal anchorage also with the help of elastic. Anchorage can also be increased. Anchorage value can also be increased by decreasing the reactionary forces on the anchorage unit. So you can do that 2 ways. You can do a two-step orthodontic correction, or you can do en masse. When you say two-step anchorage correction and en masse anchorage correction, you're basically saying that instead of moving all the teeth at the same time, you can move some teeth at once, so that by doing this, you're having only lesser number of teeth to be moved in the first step, hence lesser force, reactionary forces exerted on the anchorage unit, hence lesser loss of anchorage. Okay, so that's the whole concept. This is an example of frictionless mechanics where a T-loop is being used to retract the maxillary canine. So by doing this, the advantage is that yes, you're having less anchorage loss. Disadvantage is that it's going to take longer time because you're doing the treatment in 2 steps. This picture represents another example of two-step movements. Now over here we can see that the canine is being distalized, and this method is called walking of the canine. So you're trying to tip the maxillary canine distally first, the coronal part distally first. Once it tips slightly, you can see that in picture 2, it has tipped slightly. Then you tip the root also. So it appears like the canine is moving or walking distally. So it's also called as tipping or uprighting of the canine. So by doing this, we know that tipping requires less amount of force. So less amount of reactionary force is exerted on the anchorage unit, hence lesser anchorage is lost. Again, the same problem. Although we are doing the whole tipping thing, lesser anchorage loss is taking place, but then again you are increasing the duration of treatment. Okay, so today we brushed through everything related to anchorage. It was an introductory lecture on anchorage. We have understood how anchorage is important, why anchorage is important, what are different ways of reinforcing anchorage, what are the cheat codes of bypassing the whole Newton's law of action and reaction by using TAD, etc. Now, the following presentations and lectures will be on transpalatal arch, transpalatal button, and temporary anchorage device in detail, appliance philosophy which utilize anchorage in their own way. Each appliance, for example, Tweed has its own method of modifying anchorage utilization. Beg has its own method of reinforcing anchorage value. So we'll discuss all that along with evidence, in the sense studies which support what's really working and what's not. Is Nance palatal button really helping anchorage? Is TPA really helping anchorage? Is it helping in horizontal plane? Is it working in vertical plane? All this will be discussed. And okay, now guys, this comes to the end of the lecture. Thank you so much for staying till the end of the lecture. I know it was a 38 minutes lecture. It was quite long. If you liked and you learned something from this presentation, please like, share, and subscribe the presentation. And in the following presentations, we'll be learning in detail about anchorage. And yes, until then, keep learning.